colleague. I'm here with my colleague, Dr. Michelle Wong, and myself, Danny Renouf. I'm a registered dietitian at St. Paul's Hospital, and Dr. Michelle Wong is a nephrologist. The two of us are participating in a few research projects together, but today we're going to tap into nutrition for chronic kidney disease and focusing on the updates on potassium and bicarbonate and protein.
And before we start, we do want to launch a poll. So we just want to know, first of all, what health authority you're coming from, and as well, if you could click on your role in the KCC team. We realize that a lot of you are joining as teams, so you could just click off as many boxes that apply in terms of who is with you in the group today. And this will just help us understand a bit more about our audience today, and we thank you for filling that out.
And while you're doing that, I will also acknowledge that I live and play on the unceded territories of the Squamish, Salish, and the Tsleil-Waututh nations and Musqueam. And I hope that you will acknowledge as well the territory on which you live. And I'm very grateful to be able to share in the land and live in this beautiful, beautiful province. Oh, there's no option for Fraser Health. So sorry about that.
Oh, sorry about that. Let me see if I can add it. Just give me one quick second.
Thank you.
Apologies, I'm not able to add anything to the poll while it's in motion, so we can
maybe collect that in the chat if that's okay.
Yeah, that's a great idea.
Thanks so much.
Okay, great. Okay, so maybe I will just go ahead in the interest of time. And thanks for filling out the poll. We will take a note of that for our future collaborations with you. So we will go through, number one, the dietary guidance for patients with chronic kidney disease regarding potassium, bicarbonate, and protein. I'm really going to spend quite a bit of time on potassium management because there has been quite a bit of change in the literature. And then I will go into talking about how to manage acidosis through nutrition. And Michelle will spend some time on protein energy, wasting, undernutrition, malnutrition. And we really wanted to make this very practical so that you can walk away and feel like there's something valuable that you can share with your patients. So this is one of the dietary patterns that is a really good starting point. You know, we're moving away from individual nutrient counseling and sort of looking at dietary patterns as a whole when we're talking to patients. And the DASH diet is a really good one. It encompasses a lot of the components that we want to make sure people are following for their kidney and overall health. And it's also been a proven diet for lowering blood pressure, which is a big factor for our population. And so as you can see in this infographic, there's a focus on whole grains, lots of fruit and vegetables, and focusing on lower fat dairy products, healthy fats, unsaturated fats from, for example, avocados, olive oil, canola oil, nuts and seeds, and then a reduction in animal-based protein as well as simple sugars, and a focus on plant-based proteins more often in the weekly eating pattern. We also have developed a beautiful Mediterranean diet pyramid, which is on our diet page on the BC Renal website. This is a handout that I really like to use, especially when patients are new to the clinic or if they ask me, what can I eat? And so this really ties into our DASH diet pattern as well. And it's another dietary pattern that has a bit of science behind it in terms of being suitable, as it is also quite plant-based. As you can see, the base of the pyramid is mostly plants and whole grains, as well as healthy oils, and drinking lots of water, which is important. And then we move up the ladder to fish a few times a week. We usually suggest 2 to 4 due to the omega-3 fatty acids and just a good quality protein without a lot of fat. And then the low-fat dairy comes next. Finally, at the tip of the pyramid are the sweets and the processed meat or meat products in general. This pyramid focuses on wine in moderation. However, with the new alcohol guidelines, we are trying to encourage people to really cut back on alcohol if possible. The plant-based diet, again, here is something that has taken a bit more root in kidney disease as well, and just another way to visualize the plant-dominant, lower protein diet, which focuses on whole grains, legumes, vegetables, fruits, nuts, and seeds. And we know that protein is something that we need to consider in a good balance. And Michelle will talk a little bit more about the details of that. And so trying to get the protein from these foods is a better profile for the kidneys and to reduce acidosis and uremia, and then limiting foods like meat, dairy, eggs, refined sugar, refined grains, saturated fat. These are kind of also part of that formula. In the initial diagram, it said avoid, but we obviously don't want to avoid these foods. They all can fit. We just need to teach our patients to create a balance. So this plant-based eating has thrown our potassium recommendations under a bit of, topsy-turvy and scrutiny, because we historically told people not to consume milligrams of potassium past a certain point, and we would encourage people to stay within 2,000 to 3,000 milligrams per day of potassium. That was the potassium restricted diet, and we took milligram for milligram. We didn't consider the source, and now we know that actually fresh fruits, unprocessed proteins, and plant-based proteins have a lower absorption of the milligram of potassium. So whatever's on the sheet of paper that says milligrams isn't actually what it is translated to in the body, because there are many factors that impact potassium absorption. So currently, we're really focusing more on understanding where the processed sources of potassium are coming from, where the additives coming from in food, and encouraging our patients to choose less processed food, try to reduce the portions of the processed food if they can, want to continue to have them, and how they can build in more fruits and vegetables into their daily diet. So the potassium recommendations per Kadoki are that, we should try to keep potassium in a normal range from 3.5 to 5. But we know that on an individual level, our patients may have a potassium range that runs a bit higher than 5. So for example, some patients are chronically at about 5.5, and there's no health risk associated with them running at that level. So the data is showing that, in fact, people with mild hyperkalemia with potassium under 5.5 don't really necessarily always need to restrict a lot of what's in their diet if they're eating fresh foods and not focusing on processed food. So I think the other thing we're going to continue to see is not really like a black and white range for potassium, but more so an individualized goal or set point for patients, especially if they have very mild hyperkalemia. And really, we don't have a lot of evidence that eating a certain food is necessarily going to raise potassium. We suspect sometimes that certain foods may raise potassium levels in the blood, but actually the scientific evidence of feeding people X milligrams of potassium above and beyond the 3,000 milligram per day, it did not correlate with dietary levels of potassium. So we know there are many factors that impact serum potassium levels. And my colleagues who are on this call know that sometimes it rounds when people say, oh, it was the spinach that they had, that raised their potassium. I always have to pipe up and say, let's not blame the food and let's look more into the whole holistic approach to managing the potassium, and I'll go into what that means next. So basically, you have a very strong system within your body that regulates your serum potassium levels, that keeps very tight control on the blood levels of our potassium. And this homeostasis is what happens under normal conditions. Most of the potassium goes into our muscle cells, and whatever our body doesn't use is excreted through the kidneys. So we have very, very high amounts of potassium that we don't need, going through the kidney if things are healthy, and we only have about 10% of the 100 percent that we would say going through the bowel. So the kidney is really primarily responsible in a 24-hour period for helping us maintain a good serum potassium level. Of course, when we have someone with chronic kidney disease, that renal excretion of potassium is impaired. Along with that, we have an impaired renin-angiotensin system, and we have a deficiency in aldosterone. And so all of these factors result in further retention of potassium in the body. The colon is very smart at adapting to the potassium that is building up in the body. And so in kidney disease, colonic excretion of potassium becomes ramped up, and the colon has a higher capacity of removing the potassium. That's why high fiber diets are so, so important in chronic kidney disease to help remove the excess potassium. And then, of course, there are drugs, there are medications, many of them impact serum potassium levels, like the RAS blockade, heparin, and other new drugs for finerenone, et cetera. There's different medications that are raising potassium on top of diuretics, on top of what people are eating. So that's another important factor to consider. And then, of course, diabetes is another major risk factor, and about 60% of my patients have diabetes. So blood sugar control is very closely linked to potassium through the insulin response. So this just shows you what types of disease states can impact potassium levels in the blood. And they're all listed there, and we can see that many of these conditions are conditions that our patients are dealing with, plus the medications that I mentioned. And finally, there are some dietary factors, mainly the synthetic forms of potassium, that can contribute to raising serum potassium levels. And then, of course, dehydration. And remember that potassium in the blood is reflective of what happened, 48 hours to 24 hours prior to that blood test. So if the person had a change in their health, had diarrhea, vomiting, blood loss, any of these things, or they're in the hospital, that serum potassium is not a really good reflection of something they may have done with their diet. So this is the study that I was mentioning, where they took a group of people with CKD, and these are hemodialysis patients. And on the x-axis, you see milligrams of potassium per day. So they tracked people, upwards to up above and beyond 4,000 milligrams of potassium taken per day, and tried to correlate that to their serum potassium levels. And the hemodialysis population is a good population to study for this, because we can control a lot more variables around potassium, such as dialysate and dialysis time and all those things. We can keep a lot of constants on people. And so they didn't see a relationship. There was no correlation between what people on hemodialysis ate and their serum potassium levels. So we can no longer say, you have to restrict to 2,000 to 3,000 milligrams per day, which is hard for patients and other non-dietitian professionals, because it's nice always to have a number to go by, but we just don't have that right now. So the faulty reasoning, as you saw in the previous slide, is that 100 milligrams of potassium taken in isn't really going to translate to X amount of millimoles raised in the blood. There are many factors that occur once we eat potassium containing foods. And one of the biggest ones is bioavailability. So if you have something that has a lot of fiber, the fiber components prevent the potassium from becoming absorbed. So even a high potassium level food like a banana or potato, the potassium absorption isn't perfect. It's not going to be 100%. Whereas if you have a juice or a soup where the concentration is higher, yes, you're going to have more absorption. Juices and soups tend to also have fiber stripped out of them. And soup boiling time as well, over an hour, tends to raise potassium levels in that broth. So removing water concentrates, cooking process concentrate, and any type of processing. So if I turn a fruit into a juice, that's processing it. If I turn a tomato into tomato sauce, that's processing it, can impact potassium levels. Again, this is complicating matters. And so it's not as simple as just saying, don't eat this food. The next layer is potassium additives. So if somebody is consuming ham, which is a deli meat, as opposed to having roast pork, although both are pork-based and both contain potassium, when we process a meat further than just roasting it in the oven, the potassium content goes up because we have to add additives now to protect and preserve that food. And so potassium additives, which are on the ingredients list, are highly bioavailable, which means they're up to 100% absorbed. And as you can see, fresh fruits and vegetables are up to 60% absorbed, but most of the time much lower than that. As I mentioned, if people are consuming more protein, especially animal sources of protein that don't have fiber in them, the potassium may go up. So there is a study that shows there is a relationship between higher protein intakes in terms of grams per kilogram per day and serum potassium levels. This is also in the hemodialysis population. So the goal here is to try to encourage our patients to eat more fiber. And so even before I explain plant-based proteins versus animal-based proteins or processed foods or anything like that, I try to encourage my patients to basically eat more fruits and vegetables. So half a plate is a really good goal to aim for, or having a tennis ball size of fruited snack. These are really good ways to remind your patients to encourage them to eat more fruits and vegetables. And it's not just the fiber content that matters. We know that the gut microbiota also change when we introduce fruits and vegetables and natural fiber sources into the diet. So there's just more to it than increasing bulk, but certainly that's an important component. The other thing that fruits and vegetables help with is acidosis, which I will go into. So here's just an example of a label. And if you want to, practice reading labels at home, if you're not a dietitian, most dietitians read labels, but if you're, interested in finding out what's in my food, especially things that you would have never thought have potassium additives like salad dressing or soups, have a look and see if you can identify any potassium additives. And the ones that are particularly absorbable are potassium lactate, potassium phosphate, and potassium chloride. So some things we do around dietary management of hyperkalemia that we think help are the double boil technique for potatoes. We try to reduce that potassium content of potatoes by 50% through double boiling, so that people can enjoy potatoes every day and just have peace of mind that it's not causing a rise in their potassium. Soaking legumes can reduce some of the potassium as well, and trying to limit soup cooking time to less than an hour, because if things stew for more than an hour, just like our emotions, things tend to escalate. And so the potassium as well can go up in soups and stews if we're cooking for longer than an hour. Choosing high fiber foods, and that can be through label reading or buying more fruits and vegetables. And frozen is also a great option this time of year when fresh isn't available. And then reading the labels for potassium additives, shopping the perimeter of the store to reduce processed food intake, and just understanding what the word processed means in terms of their specific diet. So is processed a juice that they might be having, or is processed a deli meat that they might be having, or chicken nuggets, or French fries, or something like that, that maybe not inherently people might think is a source of potassium. There's also a big movement towards vegan products, and a lot of vegan products do have additives, so it's really important to read the label. And when you get a consult or you notice a high level of potassium for a patient, it's really good just to do a quick cheat sheet, and you check for the following things. Were they hospitalized? Have they recently had surgery or blood loss that's significant? Have they had any medication changes or diarrhea, vomiting, illness, anything like that? Illness can push up blood sugars as well, or was it diabetes medication discontinued for them? Did they forget to refill it? There's all these variables, and as you can see, it's not always just saying, did you eat bananas, and stop eating bananas. It's more complicated than that. So I really hope, if anything, you walk away being a bit more critical in terms of your assessment, so that you're providing patients with valuable feedback rather than just a do and don't list of what not to eat and what to eat. Of course, constipation is something our patients struggle with a lot, and that's something we can all ask about. And over-the-counter herbal supplements and salt substitutes is another really good question to ask about. Then once you've tapped into the non-diet related factors for hyperkalemia, it's great to check in and find out, what beverages are you drinking? Are you drinking those specialty coffees every day? Are you having juice? Do you know if your food contains additives? Are you having snacks that you didn't think had sugar in them, or are contributing to raising your blood sugar? Processed cereals, are you eating more animal-based proteins or more processed meat? And then you can ask about the potatoes, the bananas, the tomato sauce, after you've sort of tapped into the more processed ingredients. So Michelle, you can jump in to this document if you want, but this is a really great go-to tool that we've linked here below, that Michelle and her team created as part of her work with ISN to help healthcare providers manage potassium.
Yeah, thanks, Danny. This is part of the optimization of RAS inhibitor toolkit. So this is just one of 5 tools, but hopefully you can find it useful as a sort of a quick reference.
Great. Yeah, it's definitely a great visual reference, and it really just puts everything we talked about up to this point into a really good infographic. So it's something you can print off and have, at your desk, so you can refer to it if you're phoning patients. And it just goes through kind of a bit of myth busting around potassium, and people are so scared to eat. So hopefully this will help your patients have a better understanding of why their potassium might be elevated. And I just want to give a big thank you to the team of dietitians I work with. We're a small dietitians group across the province. We do all our projects off the side of our desk without really any resources or supports. And we're so fortunate to have a great group of dietitians working on our handouts. Stacy and Cynthia from BC Renal always help us format them beautifully. And this one is found on our BC Renal Diet page to talk about how to manage potassium. So it is 5 pages, but you won't see a food list of medium, low, high potassium foods in milligrams for the very reasons that I outlined previously. Because we want to promote healthy eating and we want to promote making sure people get enough nutrients, that they're not over restricting those really, really important high nutrition foods. So next I'll go into bicarbonate and acidosis management, which is, again, very evidence-based, and there's a lot that can be done with nutrition. So as you can see with metabolic acidosis, which tends to happen when kidney function declines and the acid levels build up in the blood, you can have bone demineralization, you can have muscle mass loss, worsening insulin resistance, and net endogenous acid production, which shows up at the serum bicarbonate levels. And you can actually get a worsening of kidney function. And the new KDIGO guidelines that will come out are actually lowering the number at which bicarbonate needs to be. However, many clinics are still prescribing sodium bicarbonate tablets when bicarbonate is around 18. I believe the new guidelines will say 16 because there's a very strong relationship between what people are eating and managing and preventing the acidosis. So again, the plant-based eating, lots of vegetables, especially the green leafy vegetables, are very, very important for people who have acidosis, and a focus away from animal products to more plant-based and less processed foods. So that's an important consideration. And there are lists of alkaline-rich foods that we can encourage our patients to have, including the nuts, the legumes, the green leafy vegetables, as I mentioned, and fruit. And then making sure the protein requirements are within the guidelines of 0.6. Sometimes we need to go up on protein energy wasting to 0.8. And we can safely do that without causing damage, especially if we introduce some plant-based proteins as part of that protein budget. For a while there were some alkaline waters that some of us were recommending to patients that had a higher level of alkalinity to them. The studies on that I have not been able to find, but I have found studies showing that a higher intake of fruits and vegetables does help to treat acidosis quite effectively. And a limitation on processed food. So here's just a table to show that the foods that lower acid load include fruits and vegetables, legumes, and generally just more plant-based eating pattern. And this is a study that was done by Goraya and their team. And this study shows that an intake of fruits and vegetables, over a 5-year period, they followed these patients, not only improved the acidosis, but also improved GFR decline. So GFR declined at a lower rate, blood pressure improved, and cholesterol levels improved. So this was just with fruits and vegetables, at a serving of about what we recommend, which is 8 servings a day. So 3 fruit, 4 veggies. And that did better in terms of all these outcomes as compared to the sodium bicarbonate or baking soda supplements, or of course, usual care. So now I'll hand over to Michelle to review protein.
Great. I'm just going to share my screen and just want to remind the audience as well, if you have any questions, you can share them in the chat box as well. We'll take questions at the end. And I just want to make sure you can see my screen okay.
Yeah, that's great.
Thanks. Okay, so protein, there's a lot of controversy surrounding protein. And so the guidelines have had moving targets in their recommended protein intake. The KDIGO 2012 guidelines for CKD recommended 0.8 grams per kilogram weight per day in patients with GFRs less than 30. And then the KDOQI guidelines, which are from the National Kidney Foundation from the US, their guideline on nutrition in CKD recommended an even lower protein intake of 0.55 to 0.6 grams of protein per kilogram of weight per day. And this was recommended for people with stage 3 or greater CKD. Now, further details on this KDOQI 2020 protein recommendation. So these, for the CKD stages 3 to 5 not on dialysis, they did quote an evidence level that was quite strong for those outcomes listed here. And then for patients with diabetes, the recommendation is a bit higher at 0.6 to 0.8 grams per kilogram per day. And in patients on dialysis, the protein intake recommendations are higher at 1 to 1.2 grams per kilogram per day because of to account for protein losses in the dialysis process. But it is important to understand that there's a lot of individual patient factors that may alter these recommendations for individual patients. So, for example, for patients on prednisone therapy or with a concurrent infection or early in a post-transplant period, the protein intake requirements would be higher. So there was a systematic review of low protein diets for patients with non-diabetic CKD. And they actually found that the evidence supporting a low protein diet really wasn't as strong as what was stated in the KDOQI guidelines. There was some evidence showing that a very low protein diet as compared to a low or normal protein diet did reduce the incidence of end-stage kidney disease. However, the outcome of change in GFR did not show a statistically significant difference. So a critique of the evidence is that there was this incongruence between the findings of the kidney failure and eGFR outcome. They didn't look at the quality or type of protein, just the quantity. And then many studies included in the systematic review were from a very earlier period where RAS inhibitors were not used frequently, so that might have affected the outcomes. And as well, low protein diet interventions are not very patient-centered in these studies. They tend to be very difficult to adhere to in the real world. As well, there's an argument that maybe low protein diets may only prevent symptoms of uremia, and maybe they don't actually affect the change in kidney function. So that was a lot of the critique that came out of the guidelines. Now, this slide here shows different types of protein. We have animal protein and vegetarian sources of protein here. The KDOQI guidelines said there was actually insufficient evidence to recommend a particular protein type. So that was the current state of the guidelines there. But there is a lot of interest in looking at the different types of protein and whether that might impact health outcomes. And we've looked at that through some of our research. So we know that diet can affect the gut microbiota via different pathways, and that a diet that's rich in whole plant foods has a lot of fiber, and that produces more short-chain fatty acids in the gut, and that can enhance the intestinal barrier function and reduce inflammation, and that has good health benefits. On the other hand, a diet that is high in processed foods or high in meat intake that has lack of dietary fiber can have low short-chain fatty acids, resulting in impaired intestinal barrier function, greater inflammation, and higher risk of disease. And in particular, there is a metabolite called TMAO, which is a gut-derived metabolite produced from the metabolism mostly from red meat. And so this metabolite is produced in greater amounts in people with chronic kidney disease, and it's associated with adverse clinical outcomes, including increased inflammation, decreased kidney function, increased mortality, and increased ischemic events. So this is a good example of how diet, especially red meat intake, may have adverse effects on the gut microbiota and health outcomes. Now, there, as Danny mentioned, a lot of potential benefits to plant-based diets and CKD. So whether that's reduced blood pressure, weight control, sugar control, as well as in reducing CKD complications. So we know plant-based sources of phosphorus tend to be less bioavailable than animal sources of food. And as well, plant-based diets can have benefits for acidosis, constipation, and may improve kidney progression outcomes, as well as being beneficial for planetary health. Now, there have been some potential concerns about plant-based nutrition, but I've listed here how we can address those concerns. So we know there may be a fear of the risk of hyperkalemia with more plant-based diets, but as long as we are mindful of looking at all the multifactorial causes of hyperkalemia that Danny mentioned and encouraging more whole foods and less processed foods, it is less of a concern. There's also a concern potentially about protein inadequacy, but we know that patients with well-balanced and diverse plant-based diets or have a nutritionally adequate diet. Because plant-based foods have lower protein content, it does help patients achieve protein intake targets. As well as accessibility, we're very lucky that our dietitians are great at considering the psychosocial aspects when they're doing their dietary counseling. There are ministry programs as well that help people access fresh fruits and vegetables through farmers markets coupons. And in terms of food literacy, there's a lot of resources available through BC Renal, videos, patient handouts, and the dietitian counseling provided in the KCC clinics, as well as community teaching kitchens. Now, so our group did a systematic review looking at the effects of plant-based protein intake versus animal-based protein intake and looking at progression of CKD. We also looked at fruit and vegetable intake as well. And this is just a snapshot of the studies that we had included. So essentially, diets that were higher in plant-based foods or plant-based proteins, this also includes the Mediterranean diet, tended to have either no change in eGFR or less decline in eGFR over time in the plant-based diets. We also saw there was only 3 randomized controlled trials. The rest were observational studies. And there was a couple studies that looked at mortality and end-stage kidney disease, which did show benefit. These were the cohort studies listed at the bottom. And there was one study that looked at quality of life, and they did show some improvement in general health and mental health scores with a higher Mediterranean diet score. All right, so I'm just going to move now to protein energy wasting and undernutrition. So there's a lot of complex interactions and consequences of protein energy wasting in kidney disease, and it's manifested as a loss of fat stores and protein stores in patients. Malnutrition is due to, or undernutrition in particular, is due to a low nutrient intake, but protein energy wasting is actually multifactorial. So it also has to do with the uremic milieu, the comorbid conditions, the metabolic disorders associated with chronic kidney disease, inflammation, fluid overload. All of those things can contribute to protein energy wasting, and it has a lot of adverse health outcomes as listed in the boxes at the bottom there. And protein energy wasting also relates to sarcopenia, when people can lose muscle mass and strength. And this is really something that can contribute to disability, reduced functional status, and frailty. So this is a really important issue to watch out for in our patients, especially in people with more advanced chronic kidney disease. So the prevalence of protein energy wasting rises as the CKD becomes more severe. So in patients with non-dialysis CKD, the prevalence is 11 to 54% in different studies across the world. And in the dialysis population, 28 to 54% of patients have it. There is a significant decline in weight and BMI after the eGFR decreases to less than 35. So this was seen in a lot of cohort studies. So this is something that you should be mindful about in patients as they have more advanced CKD. The diagnosis of protein energy wasting has been done through a very strict criteria here through the International Society of Renal Nutrition and Metabolism. So there's 4 main criteria categories, including serum chemistry abnormalities, dietary intake, low dietary intake, low body mass, and reduced muscle mass. And there's various tests and different ways that each one of these parameters can be assessed. It is a little bit difficult to use in the real world to apply all these criteria. So what we find is helpful to use is a subjective global assessment. And dietitians are experts in performing this assessment, and there are criteria to define protein energy wasting using this subjective global assessment. There's also another score called malnutrition inflammation score, which is sort of based on the subjective global assessment plus some lab parameters. And just to remind you, BC Renal has an oral nutritional supplement program that is stewarded by dietitians. And this is a great resource for patients to have these supplements available free of charge. And there's renal specific formulas as well as protein only supplements. So the dietitians really work with the patients to figure out what are their nutritional requirements, as well as what does the patient prefer in terms of tolerability, palatability, and the dietitian also decides on the length of the duration of the oral nutritional supplement therapy. Okay, I'll pass it back to Danny on exercise to wrap up.
Thank you so much. So I think I'm wrapping up with probably the most important topic, because a lot of us do talk to our patients about nutrition, but more of us, and probably all of us, could be talking to our patients about the importance of exercise. You know, nourishing well is an important piece of protecting that muscle mass, but without proper movement, it's very difficult to counteract the negative effects of frailty, of sarcopenia, of the pro-inflammatory system that's going on with multiple chronic diseases. So we're so fortunate to have the Kidney Wellness Hub now as a great resource for a multitude of different exercises. So definitely check out the Staying Active page on the Kidney Wellness Hub website. And you can really see that there's an exercise program for everyone and anyone. So there's seated exercises, there's dancing, there's strength training, there's a walk program. So lots of ways to motivate people at different levels of fitness to engage with other people living with kidney disease to stay active. And the benefits of exercise just cannot be underscored. You know, they did a really big Cochrane review here. And as you can see, exercise reduces the risk of basically mortality and morbidity. That's the biggest thing. And at any point in time, people can start exercising and see benefits. So I think it's important not to feel like, you know, there's no choice or no hope for certain patients. Anyone and everyone can add some movement that is safe for them and potentially improve their health outcomes and quality of life. A number of years ago, we did a Nordic walking study, and we had a small group of participants, 30 participants who enrolled, and they did the walking program with us once to twice a week. And people improved in quality of life. Their hand grip strength actually improved, which was really interesting from walking. And a lot of people had better 6-minute walk speed and sit to stand tests as well. So that was just a small study that we did, but the difference over that study period was really important. It mattered to patients. So I think this is a really patient-centered approach. And yeah, so just to note that most studies have been conducted in aerobic exercise, and really future studies, if any of you are interested in doing something like this, there's really good opportunities as well to engage in a study to look at resistance exercise and its benefits over time on morbidity and mortality. Patients are curious about exercise. They want to know what's permissible. And so I think it's really important for us as providers to be educated, to give people options, and not to just sort of defer or ask them to ask their doctor whether it's safe. You know, anyone can engage in exercise within the recommendations that they've been provided. So yeah, so I talked a bit about, sorry, just if you go back to the slide again, I talked a little bit about sort of the importance of exercise, not just for physical outcomes and longevity, but also for emotional well-being and emotional health. And just that quality of life piece is so, so important for our patients. Thanks. Yeah, so the whole myth that aging muscle doesn't respond is no longer the case. And resistance exercise is particularly important for our aging population. So even simple seated exercises starting at 5 to 10 minutes per day can really improve physical functionality, range of motion, you know, independence with daily activities, improve diabetes control, and just increase strength and muscle diameter as well. Great. So in conclusion, nutrition care is important, more so now than ever in the progression of CKD, as we're learning more about the impact of nutrition on outcomes over time. So speaking with your team around dietitian referrals when the dietitian can step in is great, but I think also consistent messaging, and this is why these webinars are so, so important, is that we provide consistent messaging to our patients and we speak the same language. That's a big piece. And finally, sorry, I just got a call and I lost my screen. Finally, please check out the resources on the next upcoming slides, because we have a really good available resources to us that we can share with our patients or use when we're providing education. Great. Thank you so much. And we can, yeah, open it up for questions. And please contact us if you are interested in being part of a potassium education implementation study. If you're interested in any type of research, you can reach out to either of us, or if you have further questions and you want to just chat offline, we're happy to do that.
There's one coming through in the chat here. In the meantime, I just encourage people, yeah, either to get them in the chat or just go ahead and unmute yourself. It's different from our previous format, so you can just go ahead and do that anytime. One of the questions is, this session has been recorded. It'll be up online, usually about a week or two.
Okay, and Tamara has a question here on so one of our patient partners, Tamara, as a plant-based patient, I'm always trying to get a variety of protein. If choline and saturated fat is in the yolk of eggs, would egg whites be a good option? And maybe Danny could address that. Oh,
Yeah, sorry. I just got a knock on my door. I ran off to get the door, but egg whites are fine. You can use them as your protein. If you go on the BC Renal Diet page, you can see that there's a protein handout, and it says that a 1/4 cup of liquid egg white is equivalent to 1 protein source, 1 protein serving. Yeah. Does that help answer the question?
Sorry, Danny.
Right.
Yeah, it does. I was just thinking because I think it's on the limit list, right? Because of the choline and the saturated fat. So I just thought I've been like, even though I'm plant-based, I've been eating like egg whites sometimes just because I like to change it up a little bit. And I thought, would it be less of a concern to not eat the yolk?
I mean, I have other dietitians on the call, but the science isn't showing to like eggs being, quite detrimental to health if you include them in a varied way throughout your diet. I mean, some people eat like 4 or 5 eggs a day. Well, then, we might need some more variety. But if you're including eggs once in a while in your diet as whole eggs, that's no problem at all. And I did say limit to saturated fat because 11%, up to 11% is okay. So
Right.
eggs wouldn't be my enemy on that one. I would say, they're still a whole food, and then they're not processed. So I'm
We get
a
such farm.
fan. Yeah, I'm
over.
a fan of them, and they're kind of cheap and cheerful too. So
They are.
that's what I like.
Thank you.
Thank you so much.
there's another comment here about probiotics. I like kefir. I find them to improve overall health when combined with prebiotics. It works even better. So yeah, I think there's a lot of interest in prebiotics and probiotics, and they can improve gut microbiota health. And so, yeah, Danny, do you have anything to add about that?
I really like that you use the example of kefir because it's a natural probiotic, and I really, really like those. I think there's just great food ways, and there a lot of, kefir is kind of like a cultural thing, especially if you're from the Middle East or Europe. So it's a beautiful food that's been around for centuries. It was discovered by accident. So I think it's a great way to add variety to your diet if you enjoy it. Just make sure when you're choosing dairy like that you try to buy the unsweetened variety though, because the sweetened does contain quite a bit of sugar, and it may contribute to raising blood sugar if that's a concern for you. So trying to go plain with the dairy would be my suggestion on the kefir.
And then Tamara had another question on keto analogs.
Yeah, so easy answer, they're not available in Canada, so we don't have to really spend a lot of time on them at this point. I don't know how people would get them unless they went to the States, and I don't know how if you can purchase them there. But they're not available in Canada, so we don't really work with those products.
Yeah, I think the Kidoki guidelines on nutrition do mention them as sort of in conjunction with a very low protein diet. So we're talking about 0.45 um, grams per kilogram per day of body weight. So that's a very, very low protein intake. So our research in particular hasn't looked at keto analogs, and yeah, we don't have practical experience with using them because they're not available here.
Okay, thanks. Yeah, I was just wondering if that was something that you guys were like starting to look at or not, but I mean, yeah. Not something I want. 'Cause, you
That's
know,
really
like
good to
food.
know. It's really good to know that that's something you may not want. I know that it's
Not foodie.
yeah, I know that it's it's a tough ask of patients. I think adherence is something that's difficult for people to make sure they're eating very, very little of the food and using those keto analogs instead. I know in PKD, and Mike, he will speak to this as an expert, but in PKD, the keto analogs have shown some benefit to helping prevent cyst growth. But again, I think maybe more research is needed before we commit. Yeah.
Correct.
And
Yeah.
this is
And
hard
in
enough.
Denver, actually, they went straight to market without actually having proper studies.
Ugh.
A recent review out of the Mayo actually says, yeah, not quite ready for prime time yet. So it's being aggressively promoted for renal health, but the evidence
Right.
is still,
Yeah, I just see it a lot more online.
yeah.
But I mean, this is hard enough, right?
The problem is after you finish keto. When you're not doing keto anymore, that's when the problem starts. It
Well,
may
that's
benefit
the
while
difference.
you're in a high protein diet, but
Oh no, that's something else.
yeah.
Yeah, so these are keto analogs, which it's not like the keto diet. These are actually amino acids. So they're constituents of proteins. So they're little particles of proteins broken down even further. And they're just supposed to help to make sure people are well nourished, that they don't run into deficiency while they're staying on a low protein diet. So
Oh,
they're
okay.
actually not fat-based at all. They have
Yeah.
the keto diet is different. Yeah.
Okay.
Thanks for that question. It's important to distinguish because it's really confusing.
Thank you.
Yeah. Great. I mean, a lot of great questions. And as you were coming to the top of the hour, I just want to thank, Danny and Michelle for just such a fantastic presentation and for, being so quick to get all these updates kind of into real world care, right? Like this has been a situation where we very quickly have been able to get this to our patients and it being a win-win. It's more evidence-based, it's better on the patient. So, thanks for doing both this session and for pushing that information out there. Really, really appreciate it.
Thank you so much. It was wonderful to see so many familiar faces, and I really appreciate everyone's time. Thank you.
Yeah. Thanks, everyone.
Thank you,
We'll
Danny.
see you
Thank
all for
you,
the next
Michelle.
session.
Thank you, Danny and Michelle.
Thanks.
Great session.
It was amazing.
Oh, thank you. Bye.
Good meeting.